So Mauro, you're asking about carbon monoxide and current vehicles?
Yeah, so with regards to the newer vehicles, I mean, it's hard for me to imagine an application where that's really going to, I mean, it's an interesting thought, but I can't imagine a situation where that really is going to change my management. And there's a couple variables in there that needs to be considered. In terms of going to the hyperbaric chamber and the indications, it's a case, in my mind, it's a case by case. There is no set level that triggers a trip to the hyperbaric chamber. Now, if they come in with 20 or 30 or whatever, sure, I'm going to talk to the hyperbaric guys, but I would not be surprised if it's a healthy male who has no symptoms, if they just said, let's leave them on the non-rebreather and let's let them blow this off. Send them on over. We may take them to the chamber, but we may not. There's a lot of variability between the hyperbaric guys and how they treat these patients. So really, like a lot of things that we do, it comes down to the clinical picture, what the patient looks like. And the other big one is the pregnant patient. All right, the pregnant patient, because fetal hemoglobin is going to hold on to carboxyhemoglobin so tight, a lot of times they're almost always going to dive these people. So I don't care if the level's 5. I'm still going to call them and say, hey, this is what's going on. Do you want to dive them or do you want to watch?
Yeah, I think that including these guys early to see what you're able to do locally, it takes some time. So even if you decided that you had the perfect patient and you really want it to happen, it's not you can snap your fingers and they're in the chamber. This is going to take some time to get them packaged, get to the next hospital, and then get the machine ready. So as soon as you think about it early, you should probably include them in the loop early, because you also don't know if that level is going to change over time. You have one data point. So our patient, we were expecting a much higher. Mario points out that the newer cars are less likely to raise it, and it turned out to be around 5 or so. Most of the time in non-pregnant adults, you're going to need double digits before they're really strongly considering it. And then, again, patient factors are more important than an absolute number. But over 20 people strongly consider it as another rough line in the sand. But there's no single number. It's really, how does the patient look? What's their expected clinical course?
Yeah, so what's their cardiopulmonary reserve? So if you have an elderly person who has severe coronary artery disease, they may not tolerate a very high level. So if they have an ischemic ACG and a carboxyhemoglobin level of 8, guess what? They're probably going diving, all right, unless there's some other underlying cause. I think it warrants to at least discuss that with the hyperbaric guys. Another clinical indication, obviously, is going to be altered mental status, right? Another clinical indication is actually do a good neuro exam on these guys. The most common finding that I've seen in carbon monoxide toxic patient is going to be ataxia. So they'll be pass pointing when you're doing your fingers in the nose testing. So if you see something like that in a carbon monoxide toxic patient, they're going diving in all likelihood. All right, and why do we do this? Why do we dive them to begin with?
Delayed neurologic.
Right, exactly. So we're trying to prevent the delayed neurologic sequela of carbon monoxide poisoning.
A couple other pearls, make sure that you remember that you can't trust the pulse ox. So always assume that they're more hypoxic than they seem. So don't trust it. And then second is that a VBG is acceptable to get the carbon monoxide level, but this might be a scenario where you want to know the PO2, depending. So keep that in mind. Might be one of the few times that you actually want an ABG, but if all you want to know is you're screening for a carbon monoxide level in an otherwise well-appearing person without respiratory distress, a VBG can still be used for co-oximetry.
Also, too, a lot of times it's burns that we're seeing in these cases, not always like a suicide attempt, right? So always in the back of your mind, just kind of toss it back there, is I always pair carbon monoxide with cyanide.
Yep.
Now, it's not very common, obviously, but you certainly want to check a pH. You certainly want to check a lactate, and then say a pH of like 7 and a lactate of like 8, 10, and it's a house fire. Maybe they're found on a mattress or something like that. Some kind of foam or plastic that was burning around them. I'd probably go ahead and treat them for cyanide toxicity.
Headache patient, not clear why, and consider it the north, the bad heater.
So here's how I try to parse through that. I'll ask them, is anybody else at home having headaches? Hopefully there's other people. And if there's everybody at home is having headache, they're getting a CO level. All right. I ask if there's a pattern to it. Is it only after they've ridden in their car? Is it only when they're at home, and then when they leave home they get better? Sometimes by the time they get to you, it's like, the headache's gone now because they've gotten out of that exposure. So that's the way that I try to parse through the CO toxicity. It's up higher on my list in the wintertime, but there's other things that can cause carbon monoxide toxicity in the summertime, right? So you still want to kind of think about that. So it's kind of hard to parse through that, but for me, I'm looking for other people around them that are having headaches, or if there's some repeating pattern to it.